Good morning, everybody. I always enjoy doing this presentation. We do this on some webinars throughout the year, and then we'll utilize some of the parts of this to educate our individuals that have spinal cord injury, as well as their families. After having a spinal cord injury, a big part of the recovery is just starting to understand your body and understanding what in the heck is going on, because things get a little bit screwed up. And so for people to start demystifying what's going on after spinal cord injury and starting to make some sense of it so that they can take care of themselves again and regain some sense of independence and control over their lives is really huge. So my goal today is to give you a baseline understanding of spinal cord injury, to educate you on what the heck is going on, what happens to the body, and then what do we do with that. If we have time, we'll do a little case study at the end, share some information about an individual that we served in the past, and the impact that some of this education had on him over the long term as well. So our objectives today, like I said, I want to give you a basic understanding of spinal cord functioning. We want to introduce the classification system for spinal cord injuries, so that we have a common language to kind of talk about when we're hearing the language revolving around spinal cord injury, as well as the associated prognostic values with those classifications. And then really the impact of a spinal cord injury on the rest of the body and what the long-term effects are. So what we can normally see, if you've ever worked with someone that's had a spinal cord injury before, what we can see typically is where they can't move and maybe where they can't feel. We can see that they're using a wheelchair, but we don't have a great understanding of all of the other aspects of their body that are affected from the spinal cord injury. So I'd like to introduce you guys to those concepts as well. And like I said, we'll have kind of a continuum of care case study at the end if we have time for that too. So we'll start out with anatomy. Again, we have to kind of lay a foundation for understanding. And what you guys are looking at right now are a couple different shots of the spine itself. So this is the bony anatomy. The one on your left on the screen would be, looking as if someone was transparent and you were looking at them and you could see through them, right? So you'd see the front of the spine, that's on your left. A side shot of the spine is in the middle, and a back shot of the spine is on the right side. So, if you guys were to reach around your back and feel up and down your spine, what you're feeling are some of those ridges, the spinous processes along the posterior aspect or the back side of the spine itself. So the part of the spine that's most prominent or most susceptible to injury is that back portion of the spine. From our front side, again, we have our rib cage, we have thoracic anatomy, so our heart and our lungs, and then we have abdominal anatomy that is kind of covering up a lot of the front side of the spine. So the part that can be more susceptible to injury is that back part, because it is a little bit more exposed. I want to go through some language and some levels here with you. So if you look at the picture on your left, and really I guess you can look at any of them, but the picture on your left of the front side of the spine, we're going to work through the cervical, the thoracic, the lumbar, and the sacral regions of the spine. So when you hear cervical, you should think of the neck, essentially. There are 7 cervical vertebrae. When I say vertebrae, those are bones. So 7 cervical vertebrae that comprise the neck. If you guys reach around to the backside of your skull, you can kind of feel a ridge on the backside of your skull, and then you can follow your spine down until you feel a bone that's a little bit more prominent. And if you guys are doing that with me right now and you've moved your fingers down your spine, you've probably found that bone that's a little more prominent. That's your 7th cervical vertebrae, C7, right? So when you see this terminology, there's a C on there, a T, an L, and an S. Cervical is related to the C. The T stands for thoracic, the L stands for lumbar, and the S stands for sacral. So when you see C7 on this picture in front of us, that's where you should have your fingers right now on your spine. That's C7, spinous process. In the cervical spine, we have a lot of motion. So again, if you guys are sitting at your computers looking at this, you can look to your left and see how far you can look to your left. Look to your right. How far can you look to your right? Look up and down. Can you bend your ear over towards your shoulder in both directions? There's a lot of rotation. There's a lot of bending that can happen in your cervical spine. We need that motion for vision purposes, right? Think about driving into work today. You had to look over your shoulder to make sure you wouldn't hit the car next to you, right? So we have to have a lot of motion in our neck. Half of that motion is going to come from the first and the second vertebrae. So our skull sits on the top of that first vertebrae, and it gives us about 50% of the yes motion. You know, if you're going to nod your head yes, 50% of that motion is going to come from the movement between C1 and the base of the skull. And then half of the no motion, so rotating your head back and forth, half of that motion is going to come from the movement between C1 and C2. The rest of that motion in the cervical spine, the second 50%, so to say, is going to come from C3 through C7. So there's a lot of movement that is going to add up between those vertebrae. They're not quite as mobile as C1, C2, but together, you add up their movement together, they're going to contribute to a lot of motion. Why does that matter? Well, after someone has a spinal cord injury, generally you're going to have injury to the bony structures as well. So if a person has a cervical level injury and they've injured some of the bony structures, the bony vertebrae in that cervical region, they're likely going to lose some amount of movement, either rotationally or being able to move their head up and down or side to side. The reason for that is when a vertebrae is broken, generally when they go in, they need to stabilize the vertebrae, and so they're going to go above and they're going to go below the vertebrae that is broken to stabilize it. So all of a sudden, you know, 4 or even 5 vertebrae that have a lot of movement combined ultimately kind of become one vertebrae because they're all connected or they're fused together. All right, let's move down to the thoracic spine. So the thoracic spine has 12 vertebrae. And as you guys look at this, you know, you might even notice those bones, they get a little bit bigger as you go down, right? So obviously your head weighs some amount, but it's only around 8 pounds, and so your neck has to be able to support your head. But then down in the lumbar spine, there's a lot more weight that has to be supported. So the structure of those bones has to be a little bit larger to ultimately be able to support the amount of weight that it's bearing. So in that thoracic spine, you see those bones getting a little bit bigger as you work down from T1 down to that T12 level. You might also notice that some of the bones that are sticking out to the sides off of those vertebrae become a little bit more prominent as well. Each one of those little bones that stick off to the sides in the thoracic spine are going to be articulating or connecting to a rib. So the thoracic spine is our rib cage region. If the cervical spine was our neck region, the thoracic spine is our rib cage region. Again, this is an area that provides some amount of movement rotationally, some amount of movement in extension, so being able to become more erect in your posture, so to say, and it's going to allow for some amount of forward flexion. But ultimately in the spine, a lot of your mobility is going to come from the cervical and the lumbar spine, and the thoracic spine is providing a little bit more stability. If we move down into the lumbar spine now, this is the low back portion of your spine. So if you put your hand across your low back region, that would be the lumbar region of your spine. There are 5 vertebrae in the lumbar region, so L1, L2, L3, L4, and L5. Again, this is a portion of your spine that has a lot of weight bearing. There are low back injuries that can happen from repetitive use in the work environment that can cause problems with the sciatic nerve, or potentially even cause some amount of impingement on some of the nerves coming off of the spinal cord. The spinal cord itself within the spine actually ends around that T12 L1 region right in there, and then nerves running off of the spinal cord continued traveling through the spinal column and then exiting out through some of the holes that you can see in that middle picture of the spine here. Okay, the last portion of our spine is going to be the sacral region, and I lump the coccyx into the sacral region. The coccyx is more commonly known probably as the tailbone, but I lump that into the sacral region. There's no nerves associated with the coccygeal area. Nerves are exiting from S1 through S5 though, and so I primarily focus on the sacral region here. So there are 5 bones that fuse together and kind of make that triangle shaped bone that you see that forms the sacrum. If you guys put your hand on your low back and then follow it down kind of in your pelvic region and put your hand up and down there, that's your sacral area, okay? Your sacrum connects your spine to your pelvic bones, which then are obviously connected to your legs. The sacral region itself, again, has a large base to it. It's a large weight-bearing area. It's also an area that if you look at it, it has those bony prominences, and maybe even if you put your hand back there, you can feel those bony prominences, but it can become an area that's very susceptible to areas of pressure sores, pressure ulcers. And so that's something that as a therapist, we're always concerned about when it comes to managing pressure reliefs after spinal cord injury and making sure that skin is looking okay too. Maybe one last thing that I want to point out before I review over this slide, because we'll keep using a lot of this language as we go on, is in that middle picture. You notice there's a couple different curves that you see. So up in the cervical region, the neck region, you kind of see this backwards bend, so to say, right? So it's a forward bend, cervical curvature, and you see a bend in the opposite direction in the thoracic spine, and then again a bend in the same direction as the cervical spine down in the lumbar spine, and then this very large curve down in the sacrum too. Those bends help support body weight. Those curves are also things that we're looking for when it comes to seating and positioning, optimal seating and positioning for individuals that have had a spinal cord injury. We don't want someone's spine to just present in this backwards C shape, right, with just one big curve, because it's going to put them at a higher risk for skin breakdown, and it's also going to constrict the area that the lungs and the heart have to work up in the chest region too, if you decrease that space with a curve that's just in one direction. So we're looking to optimize the spine when we're doing seating and positioning work with individuals with a spinal cord. All right, so just to review before we go on: cervical, thoracic, lumbar, sacral regions. Cervical region has 7 bones, the thoracic region has 12 bones, lumbar region has 5 bones, sacral region has 5 bones that are fused together. The cervical region again provides a lot of movement. The lumbar region also provides a lot of movement. The thoracic region is going to have our rib cage connected to it, all of our ribs connected to it, and it's going to provide a little bit more stability in that region. You guys might also be wondering, what are those blue things in between all of the bones? Those are vertebral discs. Those are going to act as cushions essentially to absorb shock with movement, and to also allow for a little bit more movement throughout the spine. All right. Let's move on. So I briefly mentioned the spinal cord running through the spinal column. So we were focusing a lot on the bony anatomy. Now let's look at the spinal cord itself. So here's the spinal cord. If you guys hold up your pinky finger in front of you, your spinal cord is about the circumference or the size of your pinky, okay? The tissue in the spinal cord is going to be much like the tissue in the brain. The tissue in the brain is very gelatinous, almost jello-like, and the same thing is true with the spinal cord, because this nervous system tissue is very squishy and gelatinous in nature. It has high blood flow to it, and there are a lot of fatty tissues that actually surround some of the nerves that are traveling through this area. So there are some layers peeled off of the spinal cord itself. So what you see kind of poking out at the top there is what you might see if you were looking at the spinal cord and you've peeled away some of those top layers. It's red because it has a lot of blood flow to it. It requires a lot of oxygen. And then some of the layers that get added on top of that are providing more structure and a little bit more stability and support to the spinal cord itself, okay? If you didn't have that, it would be very easy for all of those nerves to just kind of fall apart. But that's an epidural sheath that's surrounding the spinal cord. If you move out to some of those arms or those branches that are coming off of the spinal cord, those become our peripheral nerves, all right? So those are going to be bringing information from the body back to the spinal cord, and also sending information from the spinal cord out to the body. The last thing I want you guys to be able to visualize from this photo are some of those bulb-like structures that are running down the sides of the spine. Those are part of the autonomic nervous system, and we're going to talk a little bit more about the autonomic nervous system here in a moment. When we're thinking about the nervous system, I want you to know where the spinal cord fits in. So we can look at this body figure on the left of this larger figure. The structures in gray are part of the central nervous system. The structures in yellow are part of the peripheral nervous system. Okay, so when we're talking about the central nervous system, that consists of the brain and the spinal cord. And the brain just in general is going to be responsible for generation of maybe movement or speech or thought or emotion. But it's also going to be responsible for perception and processing, right? So understanding, making sense of what's happening out in our world or our environment. The peripheral nervous system then is responsible for either delivering those messages from the brain or bringing the messages from the body back up to the brain. And the spinal cord itself acts as this mediating conduit in between the brain and the body. So it's going to be this superhighway transmitting information from the brain out to the body via the peripheral nervous system, or transmitting information from the body back up to the brain from the peripheral nervous system. Okay, so I'm sure you guys, you remember your special senses, right? So being able to smell, taste, see, have balance, and hear. We also have these touch receptors out in our body that are providing information about where we're at in space, right? And what we're touching. Are we getting, how much pressure are we getting? Are we feeling a pain sensation? Or even the difference between hot and cold. So there are a lot of different types of just sensation that we can bring in and send up to the brain. Another part of the peripheral nervous system is the autonomic nervous system. When you think autonomic, you can think more automatic, right? So autonomic is going to have more automatic functions, and that differs from skeletal muscle, which is, again, going to be controlled through that peripheral nervous system. That skeletal muscle consists of the muscles that you would generally just move on a daily basis, right? So if you're sitting here and you're writing with a pen, or if you're just trying to keep yourself upright and trying not to fall asleep while I'm talking, you would be using skeletal muscles, right? Autonomic nervous system, again, is going to be more associated with automatic types of functions. So those parts of the body would be related to the digestive system. So digestive system has smooth muscle that helps things move through it. It also has smooth muscle in the bladder. So when the bladder expands because more fluid goes into it, it will send a sensation to our brain that says, hey, are you in a good spot to use the restroom or not? And we might say, no, I'm not. I need to wait a little bit. And you can use skeletal muscle to hold that in. But that stretch on the smooth muscle isn't something that we have to think about until it comes to our conscious awareness. The ability to keep yourself warm when it's cold. We might get the goosebumps or goose pimples. That's your body's attempt to keep heat inside. On the other side of things, if it's hot outside and you've gone outside on a really hot day and you're working and you're sweating, right, your body's going to try to release heat, and so it's going to sweat. The ability to do that can be lost after a spinal cord injury due to damage to the autonomic nervous system. Those are smooth muscles that are controlling those glands that allow us to either sweat or even hold in heat. cardiac tissue, the heart muscle, right? All of the veins and the arteries that are associated with our cardiovascular system. There's some amount of control to either open up or close big or small arteries to maintain adequate pressures, as well as the muscle in the heart to pump harder or to pump slower based on the demands placed on it. All of those things can be affected via the autonomic nervous system being affected. Last thing I want to show you guys is kind of a slice through the spinal cord itself. All right, so this is the last piece of anatomy. Hopefully I haven't lost you yet, but I talked about the spinal cord being this super highway carrying information between the brain and the body. What you guys see on here are some areas highlighted in blue and some areas highlighted in red. The areas highlighted in blue are going to be carrying sensation types of information from the body back up to the brain. The areas that are highlighted in red are going to be carrying movement types of information from the brain out to the body. What's interesting about this is we have these areas mapped out pretty well. So, you know, when it comes to research that's being done on spinal cord injury or spinal cord injury care, or even being able to help people potentially regain more movement after a spinal cord injury, scientists are looking very specifically at these areas. Where are they damaged in the spinal cord, and how do we bridge the gap, or how do we help regenerate some of the pathways that have been damaged through these superhighways that you guys are looking at, right? So there's large words on here that don't make a ton of sense all of the time, and you don't need to remember them, but those large blue areas that you see on there, that's actually the back of the spinal cord, and the cluster of red areas opposite of that is the front of the spinal cord. That cluster of red areas in the front and kind of in the middle are going to be more associated with muscles of the trunk, right? So of our stomach and our rib cage, along our spine, they provide a lot of postural support. And the cluster of red dots off to the sides are going to be more related to movement in our extremities, so our arms and our legs. From a sensation side of things, the large blue areas toward the back of the spinal cord are going to be carrying information related to proprioception, which is, you know, our body awareness, our body sense, knowing where we're at in space. So if I had you close your eyes and I had you kick your legs straight out, you'd be able to tell me that you were able to kick your legs straight out. But if I asked someone the same thing that had lost proprioception, their awareness of where their body's at in space, they would not be able to tell me which direction their leg was moving. That's very interesting, especially if that individual is able to stand up and take steps, because that sensation awareness and body awareness is going to impact an individual's ability to remain upright, to balance themselves adequately, and be safe with any kind of ambulation. The blue side, or the blue areas over on the sides of the spinal cord picture here, are more related to pain and temperature and light touch. Okay, so again, we have things mapped out pretty well, and it gives us what we see, what manifests itself when we're doing an evaluation on somebody, or when the neurologist does an evaluation on someone, or the physiatrist does the evaluation on someone. What manifests itself, we can kind of understand, because we understand this picture, we can understand what areas of the spinal cord might be a little bit more damaged, okay? All right, we'll get into a little bit more terminology here. This is stuff that you guys have probably heard a little bit more of as well. Paraplegia versus tetraplegia. These are words that often get confused, and we certainly don't define individuals that have had a spinal cord injury by these words, but it helps us understand, especially when we're reading notes on people after their injury. It's helpful to understand a lot of these words, right? So paraplegia is related to an individual who's had a spinal cord injury, but they only have their lower extremities or their trunk affected. Tetraplegia, on the other side, is referring to individuals that have all four extremities affected. Tetra means four. You've also likely heard quadriplegia. They're interchangeable, so tetra and quadriplegia are the same thing. One of them, so tetra is a Greek prefix, and quad is a Latin prefix, I believe. So they're different. You'll see both of them in notes that you read likely. So tetraplegia, again, all four extremities are affected, lower extremities and upper extremities. And with paraplegia, just the trunk or the lower extremities are going to be affected. You'll have full use of your arms. So what does that mean coming back to the anatomy that we looked at? Tetra or quadriplegia is going to exist in an individual that's had an injury in the cervical region. Okay, anyone that's had an injury in the cervical region can have their spinal cord injury described as tetraplegia. Anyone that has an injury at the level of T2 or below is going to have trunk or lower extremities affected. All right, and that would be paraplegia. Okay, so we're going to move on a little bit to classification system. The classification system that's often used with spinal cord injury to define a neurological level of injury is an ASIA scale, or you may even see the INSCI scale, so the International Standards, Neurological Standards for Spinal Cord Injury Classification. You may hear that in other terms as the American Spinal Injury Association scale. Whatever it is, you're going to come to a neurological level of injury where you get someone that has maybe an incomplete C7 spinal cord injury, right? Or maybe it's a T6 complete spinal cord injury. We'll get to some of the letters and the words that define that. Before I move into this too far, I do want to just note back on the last slide, as we talked through tetraplegia and paraplegia, and we tried to connect that back to the anatomy that we were looking at. You can think of the flow of the spinal cord, you can think of it as similar to, a river, right? So if something happens upstream in that river, everything downstream is going to be affected, if that makes sense. Right? So if there's a dam upstream in a river, you're going to get less water downstream in that dam. If you open the floodgates on a dam upstream in a river, that's going to affect the amount of flow downstream in a river. Same thing with the spinal cord, right? So if you have an injury in that cervical level, upstream, so to say, everything below that level is going to be affected. It's not just at that level. If you have an injury at the T12 level in a spinal cord, everything below that level is going to be affected. Everything above will still be good, but everything below that level will be affected. Okay, let's move on to some of the classification systems. So again, I kind of covered what these are called. Ultimately, they're a system of tests that we use to define and describe the extent and severity of a patient's spinal cord injury. They also help us determine, prognostic indicators, right? So future rehabilitation and recovery needs. And ultimately, the patient's grade is based on how much sensation he or she can feel at multiple points on the body, as well as specific tests of motor function. So I'm going to skip ahead real quick. So this is the form that a neurologist or a physiatrist or a physical therapist, occupational therapist, kind of depends on the setting that a person is in. These are the forms that they're going to go through when they do that evaluation, right? This is a standardized test that's done with spinal cord injury. And I mentioned that we're going to look at key sensation points. So if you look, there's sensory columns on both sides, and those sensory columns go from the level of C2 all the way down to S4 and S5. And if you look at the little picture of the person in the middle, all of those sensory points are outlined, again, standardizing how the test works. And then there are movement functions off to the sides, so motor key muscles, if you look at that picture, and you look at C5 through T1 as well as L2 through S1. There's not a great way to manual muscle test the region between T2, so thoracic level 2 down to thoracic level 1, which is why we muscle test the key motor muscles that are listed on this examination. So what we do is we ultimately look at dermatomes and myotomes. So we're looking at all those key little points for sensation. Again, we have a map for these things. So there's a dermatome map that can tell us, where C4 provides sensation, where the level of T6 provides sensation, where the level of L3 provides sensation. So this is standardized, right? And myotomes then are muscle functions, so the motor tests. We know that elbow flexion or the bicep muscles are represented, or they are representing the C5 level. The C6 level is represented by wrist extension. C7 level is represented by tricep extension. C8 is represented by being able to close your fist and curl your wrist. T1 is being able to spread your fingers, and so on, right? So we have all of this mapped out, and we're able to test that, put the numbers into the system, and ultimately spit out what's the neurological level of injury. And when we determine a neurological level of injury, it's the lowest level that still has normal sensation and normal movement. Below that level, you could still have movement and you could still have sensation. It's not just a clean cutoff. So you could still have movement, you could still have sensation, but the amount of sensation might vary. It could be diminished. So they might be able to feel a dull touch, but they can't locate just a sharp touch in that dermatome, right? Or they might have normal movement down through the level of C7, so they can straighten out their elbows and they can bend their elbows just fine and they can move their shoulders just fine, but they might be weak at C8. They might have a hard time squeezing their fingers and making a fist. They might have some weakness down through their legs, or nothing at all in their trunk and their legs. So again, coming back to that analogy of things are affected downstream in the river, right? That flow is affected downstream in the spinal cord. If you have a C7 level injury in the spinal cord, everything below that is going to be affected. But we can have varying amounts affected in the spinal cord, and that leads us into this concept of an incomplete versus a complete injury. So a complete injury is an injury where nothing is getting through that C7 level. Since we're using C7 as an example, I'll keep coming back to that. Nothing is getting through that C7 level. It's been injured enough that you're not able to get sensation information back up to the brain, and you're not able to get movement information through that C7 level down to the body. All right. That doesn't mean, especially early on, that could change. It could as the spinal cord heals. Maybe some connections are made, right? And it could shift to an incomplete injury. A complete injury would be like having the floodgates completely shut in a dam. Nothing is getting through. An incomplete injury, on the other side, has a large spectrum, right? You can open up those floodgates just a little bit. You can let just a little bit of water through, or you can open them up all the way and let a ton of water through, or obviously anywhere in between that, right? So there are varying degrees of information that could get through in an incomplete type of spinal cord injury. So just to go through this real quick, the definitions that we have on here. An incomplete injury means the ability of the spinal cord to convey messages to or from the brain is not completely lost. So some of the sensation, some of the movement is possible below the level of injury. A complete injury, on the other side, you're not getting movement, you're not getting sensation through that level of injury. Okay, it doesn't mean that the spinal cord is just completely severed and that nothing is still intact there. It just means that nothing is getting through at that time. So we have different classifications to define complete and incomplete. So complete is a grade A, right? That's the complete lack of movement and sensation function below the level of injury. A grade B, you're going to start getting sensation through. So again, using C7 as an example, we might have some sensation down in C8 and T1 and down into T6, T7 maybe, right? A grade C, an individual starts to get some amount of movement in addition to that sensation below the level of injury. However, the movement is not enough that it's going to help them propel themselves into an upright position against gravity. Maybe it's a wiggle of the toe, maybe it's a wiggle of the foot, maybe it's a little flicker in the quads, the thigh muscles. Um, it's some amount of movement below the level of injury, but not enough to propel themselves up against the force of gravity. A grade D is an individual that's going to have more than half of the muscles below their level of injury, and those muscles are going to be strong enough that perhaps they can propel themselves up against the force of gravity, right? So this is a person, maybe if they're sitting on the edge of the mat and they have that C7 level injury, maybe they can balance pretty well because they actually have some movement in their trunk. Maybe they can kick a leg out. Maybe they could stand up, but they need balance support. Perhaps their sensation is still affected and they have ability with proprioception, that body awareness that we were talking about earlier. Maybe they can't quite feel hot and cold because their sensation is a little bit messed up. All right. And grade E is an individual that has had all of their neurologic function returned. So just to kind of put a lot of this together, what you might see on paper is an individual with a diagnosis of a spinal cord injury, but that spinal cord injury is labeled as a C7 Asia or AIS-C injury. So you could read that and you could say, I know that they had that injury. It's in their neck. It's at the bottom of their neck because I know it's the 7th cervical vertebrae. And I know that it's incomplete because it's a grade C. And what am I thinking about a grade C? A grade C, okay, they have sensation below that level of injury. And they might have a little bit of movement, but I'm not quite sure how much movement they have, right? That grade C it's a large range of movement progression that happens to get to a grade D. And these aren't just stair steps, it's more of a continuum, right? If you want to think of it that way. So you don't just all of a sudden hop from a grade A to a grade B, and all of a sudden from a grade B to a grade C, and so on. It's kind of this continuous spectrum, and you see people that if they're making some progress after their spinal cord injury, they might be gradually gaining some movement or sensation information back. Okay, I hope I haven't lost all of you guys. This is a lot of information that we're throwing at you, but again, I hope that it's helpful just to get some of the language out there and to help you understand what you might see on paper and have awareness of what some of this terminology, or at least a better awareness of what some of this terminology may mean. Okay. One last thing that I want to talk about in this section is some of the prognostic indicators, because I have alluded to that. A complete injury, so that grade A, again, that's an individual that's not going to have information getting back through the area of the spinal cord injury that's been hurt. You can imagine that we're always looking at trends, right? And you can imagine that the further away from your injury that you get, the slower that progress might come. It doesn't mean that the progress can't still come, or that changes can't still happen, but the further away from your injury that you get, the progress slows down, right? The closer to injury you are, you should expect that there's going to be a higher rate of progress that happens. If I were to graph that out, I don't have the ability to mark up this screen or anything, do I, guys? No, I'm getting no's. I don't have the ability to mark up the screen, so I'm going to try to describe a graph for you, right? So if you can imagine an x-axis and a y-axis. On your x-axis, going sideways horizontally, what you're going to have is time, and on your y-axis is going to be progress, right? So the further out on time, you're going to expect the progress starting to flatten out a little bit more on the graph. The closer you are to that injury, you should expect the graph to have a higher amount of progress. So a line that's going up a little more vertically on that graph. It might be a terrible explanation. Some of you maybe followed me, some of you maybe didn't, but hopefully that makes a little bit of sense, okay? Another part of that prognosis is someone that has that grade C or a grade D type of injury. Closer to their injury, you would expect to be a person that's maybe up on their feet and doing some amount of walking. The person that has a grade A or grade B closer to injury, they might progress to a B or a C, right? Generally, what you are within those first 72 hours after injury, you have the ability to move 1 to 2 grades higher over time, right? Um, there are exceptions to that rule. There are exceptions to those guidelines that have been put out there. Obviously, you can't just apply that to everybody. But those are things as a physical therapist working with people that have had spinal cord injuries, those are things that I'm thinking about as I'm giving them education, emotionally as we're helping them through some of the things that they're working through, and as we're planning out some of the items that they might need for durable medical equipment and planning out the rehabilitation in general. Okay. So we've talked a little bit about, well, a lot of it about kind of the sensation and the movement aspect, but I alluded earlier to the autonomic nervous system, right? And the autonomic nervous system is controlling some of those areas that we just don't think about. It's automatic, right? And I also alluded at the beginning of this presentation to the fact that what we can see as people that are maybe serving individuals that have had spinal cord injuries is that maybe they're using a wheelchair, and they might move around differently, they might transfer differently, maybe their arms look a little bit different. I can see they can't move the same. If I asked them, I might be able to tell that their sensation isn't normal, right? But if we look at this slide, these are all of these secondary conditions that come along with a spinal cord injury that we don't always think about and that aren't easy for us to see, right? Pneumonia, low blood pressure, pain, pressure sores, bladder and urinary tract infections, autonomic dysreflexia, spasticity, blood clots, bowel management. I'm going to give a high-level overview of each of these areas, but when it comes to quality of life, these are the items that are primarily affecting people with a spinal cord injury. These are the items that rehospitalize people with a spinal cord injury over the long term, okay? And these are the items that people are having to learn and understand more about their body to be able to live independently and regain independence and control on a day-to-day basis. And these are the items that people may need caregivers for as well. From a pneumonia standpoint, if you have a cervical level injury, a lot of your breathing muscles could be affected. Pneumonia happens when we get bacteria in the lungs, and that bacteria are going to basically start to take over if there's an environment that is acceptable to them, right? Well, how do you get an environment in the lungs that that bacteria love to be in? It's not clearing out your airways well. So if you don't have the ability to exhale air quickly, to cough, right? If you or I get a cold, we're able to cough up the stuff that kind of builds up in our airways in our chest, and we're able to get it out. Individuals with a cervical level spinal cord injury that maybe don't have the ability to cough very well to clear their airways are more susceptible to pneumonia, especially from the common cold. Pressure sores are going to happen because of a lack of sensation. A lot of our individuals with spinal cord injuries are going to be in seating and positioning systems, and we have to figure out what the right cushion and what the right fit in that seating and positioning system is going to be. We also have to think about bed surfaces that they're going to be on and how often they need to turn. And we need to teach people how to check their skin as part of their morning routines, as part of their evening routines, so that they get in the habit of looking at their skin rather than feeling their skin. They need to be able to pressure relieve in a manual wheelchair and in a shower type of chair and in a power wheelchair. Pressure sores are going to happen from being in one position for too long a period of time. And what happens when you're in one position for too long of a period of time is you cut off blood flow to the area. When you don't have blood flow, you don't have oxygen. When you don't have oxygen, those cells are going to die. And so you or I, as we've been sitting here, we've probably shifted around a number of times without even thinking about it. Our body is just going to tell us, hey, I'm not comfortable anymore, and so you naturally shift. But if you or I just laid in one position for a long period of time, we too could have pressure sores. Autonomic dysreflexia, again, that's basically something is wrong with your body and you need to respond to it. So our autonomic system, again, is responsible for some of those automatic functions. And if something like a catheter hose gets kinked or clogged, or an individual is constipated, or let's say they have a wrinkle in their pants, in their chair, Perhaps they're too hot from being outside and they can't sweat. Any number of things like that. Their body is going to do something called autonomic dysreflexia, where it's going to it can do a number of things. It can raise their blood pressure, right, to a point where it could potentially cause a stroke. It can make them feel nauseous. They can have a pounding headache from that rise in blood pressure. And that can become a medical emergency if it's not addressed immediately. All right. All you have to do, though, is figure out what's going on, and you need to fix the situation. So if it's a wrinkle in the pants, let's do a quick pressure relief and let's get the pants straightened out, right? How do you know if it's constipation? Well, you'd have to ask the individual, when was the last time that you had a good bowel movement? How many days has it been? That could be causing autonomic dysreflexia. In that case, the individual needs to have a bowel program, a bowel treatment as soon as possible. If it's a catheter hose that's clogged, perhaps it's just kinked. It needs to be unkinked. So we need to check that and make sure we unkink it, right? If it's clogged, it might need to be flushed very quickly, all right? So if we're hot because we've been outside for too long, we need to come inside into the cold, or we need to have strategies like a cold towel or a cold cloth or a spray bottle that we can go out into the sun with. Blood clots happen from a lack of movement, essentially, right? So if an individual is in bed for an extended period of time, this is often when DVTs, blood clots, are happening because they're laying and there's not a lot of movement happening to help some of that blood get back up to the heart. So it's going to pool in that area and potentially cause blood clots. Bowel management, people have to learn how to manage their bowel programs on a regular basis after a spinal cord injury. Coming back to the anatomy that we learned about, there's a cutoff in that T12L1 region. Individuals that have a spinal cord injury below the level of T12 or L1 are often going to have a flaccid type of bowel, right? And they're going to need to do a bowel program more often to clear out their bowel. An individual that has an injury above that T12 or L1 level are going to need to do a bowel program a little less frequently. They could go every other day, and they're going to have something called a spastic bowel. Okay, I had a question that just came in asking to elaborate on bowel program and digital stimulation for cervical spine injury versus use of laxatives and enemas. I'm not going to have a fantastic answer for you on that question because it just depends. So when we're talking about a cervical spine injury, again, we could be talking about someone that has a complete injury versus someone that has an incomplete injury. So anywhere from an ASIA A down to an ASIA D. Likewise, things that we have to consider when it comes to a bowel program are, when did you go prior to your injury? Were you fairly regular? What did your diet look like then? What does your diet look like now? What kind of a stimulus are we using before your bowel program, right? So if you were a person that went regularly in the morning, was that happening after you'd have a cup of coffee and after you would have your breakfast? So how do we use some kind of a stimulus from the top, so to say, something that goes into the digestive tract that is going to stimulate what we call peristalsis, or movement of the bowel? And then would you use something from below as well? That could be using an enema, that could just be doing digital stimulation. So we're always trying to get away from putting things in the bottom if we can. If we get to the point where we just need to do a digital stimulation, that would be ideal because it makes it a little bit easier for the individual to do that on their own too. So I'm sorry that's not going to be a just straightforward answer, because there's a lot of things clinically you'd have to consider in that situation. Have another question that's asking about temperature irregulation issues and at what level of injury it's most common to have those. So the autonomic nervous system is going to affect temperature regulation, and the autonomic nervous system is going to be affected in injuries at the level of T6 and above. You could have a little bit of variance around that T6 level, so a T7 injury, T8 injury could still have that, but T6 and above are going to have autonomic nervous system affected and could have temperature regulation issues affected as well. There are people that have incomplete injuries that are able to manage their temperature a little bit better, and some that have those incomplete injuries that are not able to do that. That's our job to go over strategies with them, whether that's don't spend as much time out in the heat. If you're going to spend time out in the heat, take a little lunchbox with ice and wet towels in it so you can put those around your neck where your carotid arteries are to cool yourself off. Okay. I have a couple more things: bladder and UTIs, pain, low blood pressure. UTIs, best thing you can do is drink lots of water and have good hand hygiene if you're doing your own intermittent cathing. We're always trying to find ways to reduce the amount of times that things are going into the body. So if someone is using a Foley catheter regularly, they might be a good candidate for a suprapubic catheter, which is going to stay in for up to 30 days. And it's something that can be changed less frequently, which means less foreign objects are entering the body. It's not uncommon for people to have low blood pressure after spinal cord injury because, again, their ability to kind of manage their blood pressures due to some of the smooth muscle in the cardiovascular system being affected from the spinal cord injury, they're unable to manage their blood pressures as well as they could prior to injury. Those generally are going to get better over time as the body adapts to it, but early on in the recovery process, you see people that go from lying down to sitting up or sitting up to standing that are unable to maintain an adequate blood pressure. We can use abdominal binders or compression stockings to assist with that, even electrical stimulation. All right. I think I'm going to wrap it up there. This last slide is just looking at, where do you go? How do you make good decisions for individuals with a spinal cord injury? Where do they go after acute rehab? Do they go to outpatient? Do they go home? Do they go to a nursing facility? Do they become a research participant? Do they go to a specialized program? Obviously, you need to consider each individual on an individualized basis. But just considering, everything that you guys just learned, we were asking people that have spinal cord injuries to know all of that information backwards and forwards, their families to know all of that information backwards and forwards. And it takes quite a while to get that and to understand your body and what you need to do. Not to mention the body is adapting over time after the spinal cord injury. It's still healing. We always kind of look at this 18 to 24 month range of healing after spinal cord injury. That's really the maturation of the process. Early on, within those first 6 to 12 months, you have a lot of healing and recovery that can happen. So you have to look at each individual and consider the amount of new learning that they have, what their support system looks like, what their educational level is, where they're going to be going after rehab. All right, there's a lot of information.